But I'll welcome back Dr. Brendan Clifford to the stage to present on Ketamine Assisted Psychotherapy for Methamphetamine Use Disorder, a pilot study. I'm sure he needs no introduction.
Thanks, Ella. I feel like people have heard a lot from me, so I'll just whiz through and then you can get me afterwards if you have any questions. So I am employed at NCCRED and also at St Vincent's Hospital in Sydney. The study was funded by NCCRED and we are supported by the Australian Common Department of Disability, Health and Ageing. What I'm presenting today is a protocol for a ketamine assisted trial, which is the team there, CAT, and really want to thank all of the investigators for their contributions into getting this together. Ketamine is a drug that most people know. It's a derivative of phencyclidine, PCP, and it works primarily but not solely on NMDA receptors. It's used widely as an anaesthetic because of those dissociative properties. It's an essential medicine. It's increasingly used for complex pain, and it's an approved medication for depression. What we're working with is a medication-assisted psychotherapy model. So on the left there is ketamine, and on the right, my right, are other psychedelic drugs, and just kind of highlights the point that ketamine has a different mode of action pharmacologically than the other one. It works primarily with the NMDA receptors, whereas psilocybin, LSD, and DMT work on serotonin. There's a lot more interest in ketamine-assisted psychotherapies. This slide is the number of studies. Over to the far right, my side is depression, which has 6 studies, and you can see in substance use as well. There's been some work in opioids, alcohol, and cocaine. There's probably a couple more there. This is a 2022 paper. How it might work is still being considered. So one of the theories is that it enhances neuroplasticity. There's some models that show that it increases the growth of synapses and connections between neurons, and as well as new neurons. They exist in kind of systems of cognitions, so functional network disruption. And you can see, especially from some of the psychedelic imaging studies, that there's functional network disruption that happens as part of those. There's also the rapid antidepressant effects, which is what signaled that it might be useful for depression. There's some lab models that show that it can affect the laying down of reward-mediated memories. There's also the mystical and psychedelic effects, like ego dissolution and insights that can be gained through those types of effects. And it might also enhance psychotherapy through a number of those, especially the accessibility treatment and the enhancement of neuroplasticity, increasing uptake of spoken therapies. Here we can see a couple of studies in other substances. So on the left, on my right, is the cocaine study in the US that looked at ketamine versus an active control of midazolam that showed an effect the last 2 weeks of a 5-week program. And on the right there is an alcohol study with one of our co-investigators, Celia Morgan, in the UK. And an early study that she ran showed a difference at 6 months in an alcohol study that compared ketamine and psychotherapy against a placebo saline control, which led us to think about how we would do our intervention. We drew on a psychotherapy model. So our working hypothesis is that ketamine will improve the uptake of an existing treatment. So we worked with the 4-session CBT intervention that Amanda Baker developed that we've used in other clinical trials. And then for the second, third, and fourth sessions of that CBT program, we gave ketamine 24 to 48 hours prior, which is said to when peaks in aptogenesis is meant to occur for ketamine. We monitored patients or participants for 2 hours post their injection by a registered nurse, including vital signs and psychological effects. And those nurses were supported to administer grounding exercise in the case of dissociative effects being felt by participants. Those dissociative effects weren't sought, as they are with some models of medication-assisted psychotherapy, but they might occur, and our CBT sessions had some brief integration and preparation to kind of support people to guide their CBT goals off of that. We had fairly broad inclusion criteria, considering this is a pilot, and we tried to balance that with real-world applicability. So treatment-seeking, stimulant use order for methamphetamine if on antidepressants on a stable dose for more than 4 weeks. Exclusion criteria included things like ketamine use disorder, other severe use disorders apart from opioid use disorder if it was stable, and those other ones there that you can see. Severe psychiatric comorbidities, contraindications to ketamine. It raises your blood pressure, so anything there can be something that you might not want to include. Anything else in the opinion of the principal investigator that would make participation hazardous. In the pilot, we're taking quite a lot of measures. You can see on the left there that we're taking most of those measures at week 8 as our primary measure of feasibility. And looking at serious adverse events and adverse events, we're using structured questionnaires to make sure that we capture the side effect profile, because often people talk about the positive aspects and not so much about the negative aspects of these types of interventions. And we're looking at time to recruit, the number of people that complete the intervention and the retention rate, as well as some secondary measures that would be preliminary efficacy measures if we did a larger trial, and looking at things like craving, quality of life, medication and therapy satisfaction, and then just a few mediators of what might be working, including depression, emotional regulation, sleep, mystical effects, and neurocognition. Our early learnings, so we have been able to recruit 17 participants to start in the study between April and October this year. We're currently on our final participant, so I'm not going to say too much about the results because I'm very superstitious and I don't want to jinx anything. Recruitment is now closed. Early findings, and we've seen this with other studies overseas, they're trying to do similar things. Intervention scheduling is a challenge. We've got that 48-hour window and a client group that faces multiple structural barriers in trying to make appointments. And also just the need for a trauma-informed approach. We've got this early on from our lived experience investigators that we were going to need to be very tuned that even though we're not a trauma-focused intervention, there will be experiences of trauma in the population group that we're working with. And so it really has brought home the need for all staff that are involved in the intervention, not just the therapists, to be upskilled and supported for that. Finally, just a big thank you to the participants who've given very generously of their time to be involved in this study, the investigator team, the study nursing team, who've done a lot of hard work, the study therapists at St. Vincent's, and the study doctors. Thank you for your time.